So we're here at HRS in Boston, and I'm very lucky to be talking to David Haines, who's been a long-time worker on the biophysics of radiofrequency ablation. I've had the pleasure to work with him over the last few years, looking specifically using an ultrasound-based catheter. And I thought it'd be a good opportunity now at HRS to catch up and just hear David's thoughts on where we're really at the moment with radiofrequency ablation and what we've learned in the last few years. David.
Thank you, Matt. I think we are at an exciting transition time in RF catheter ablation, applying some of the basic biophysical principles that we've known about for decades now, but using those data in new and creative ways to create more effective, safer, and better RF lesions. One of the observations that we made when I was doing experiments, preclinical experiments with Matt, was that occasionally with irrigated tip catheters in thin-walled structures like atrial appendage, we would open the heart and there would be no lesion. And in fact, we would see lesions outside the heart in the lung or other contiguous structures. And we started thinking about that. Of course, it made sense. High irrigation flow, surface cooling, and subsequent deep heating was a good formula for making deep ventricular lesions for arrhythmias such as ventricular tachycardia, but didn't make a lot of sense for making lesions in thin wall structures like atrium, and in particular could increase risk of esophageal injury and the dreaded complication of atrioesophageal fistula. Using this ultrasound tip catheter, we saw often that the lesion would start growing in the subepicardium and extend up to the subendocardium. So it brought up the notion, gosh, what would happen if we turned up the power, turned down the irrigation, and then limited the depth of ablation by just having very short duration? And that, in fact, is what a number of investigators have done.
Yeah, and we saw this threshold effect where we could not have a lesion grow, and then we'd have to change something, so we could be ablating for about 30 seconds. We wouldn't see any changes, and then we either reduce the flow rate or increase the power. What do you think about the high power ablation?
So I think that the high power ablation is, again, something that we experimented with decades ago, but I'm delighted that it's making a resurgence. What happens with high power is that you get peak heating very close to the surface, and so you get a wide and shallow lesion. Now, if you stay on power for 15, 20, 30 seconds, you can get very deep ablation, but then you'll get pop lesions and complications associated with excess power. But if you limit it to short duration, and in particular, if you've got an accurate method for preventing excess delivery, like surface temperature recording or our system using ultrasound imaging, you can create a safe lesion that's superficial but broad. And that, I think, is the ideal lesion for atrial ablation in our AFib patients.
And one of the issues we have at the moment is that whilst we have a recipe to do ablations with either a certain amount of power, a certain amount of time, a certain irrigation flow, a certain sort of a force or pressure, we don't really know how thick the tissue is. So how do you think the future will go in terms of really trying to titrate lesions per individual bits of myocardium?
Yeah, I think that summarizes the challenge in our field right now. We've used surrogate metrics for lesion formation for as long as we've been doing this. We adjust power, we look at impedance, we look at signal attenuation during energy delivery. And these are all good. We use the force time integral or the LSI, whatever system you're using. There are all of these surrogate measures for lesion transmurality, which is our goal. But there's nothing that we've got available to us today that actually tells us we're creating a lesion and this is exactly how big the lesion is and how deep it is. That's why we were very excited to work with this investigational tool which incorporated ultrasound crystals at the tip of a catheter and allowed us to look into the tissue to actually see the lesions as they were forming. And we learned all sorts of exciting things, didn't we?
Yeah, for sure.
So Matt talked about this threshold effect. You know, all of us, at least I, used to think, you know, it was a pretty linear type process. You turn up the power a little bit, you get a little bit deeper lesion, but no, we would see cases where there was no lesion, no lesion, no lesion, and we would go up from 25 to maybe 30 watts, and then boom, we would see the lesion start to form. So we still don't exactly know why that happened, do we?
No.
What's your hypothesis?
It's very hard to say. I think the active cooling is something that we've probably not really thought about. Right? As soon as you do start to think about it, it's obvious, like most good ideas. But I actually think you have to overcome that, and whether you overcome that by decreasing the flow rate or increasing the power, until you do, you're just not going to get a lesion.
Right. And we'd also see latency of onset of lesion formation. And again, maybe it's a little bit of sliding catheter contact, and then maybe just as the ablation really starts, you have perhaps loss of local contractility, allowing the catheter to settle more and energy coupling to improve with the tissue. The point is that there are a lot of factors that we don't control, and we don't see it because it's blind, it's in the heart. But if you've got technology that's actually reporting back the actual formation of the lesion, you can adjust your parameters, your power, duration, flow rate, etc., to optimize that lesion.
So when you're in the lab now, how do your observations and your sort of basic science knowledge and basic biophysics influence how you do an ablation? You've presumably got force sensing catheters. And
absolutely.
There's all the studies now, like Matthias Duchava's work on, you know, we've got a magic number of 400 and 550.
Right.
But again, it's a surrogate measure.
And I think there's some danger to that.
Exactly, that was
because
what I was thinking.
There's a strong suggestion that there's been a spike in esophageal injury in the era of force sensing, and I think this notion that you have to earn your dot, you have to make sure to hit that FTI of 400 before the technician will put a lesion on your screen, has led operators to deliver too much power to critical areas like posterior left atrium, and I think that's resulted in this spike in esophageal injury. So what we do practically now, we only have the capability of going up to 50 watts, but I use 50 watts typically for 5 seconds. Now I monitor lesion formation with intracardiac echo.
Yeah.
I use the rotational ICE in the left atrium. I actually watch the lesion formation, and you get a typical signature of tissue brightness when you are a little bit past the point that you should be. That usually implies you've got microcavitation and maybe bubble formation in tissue, and we come off power immediately if we see that. But if we see a change in the tissue signature, we cut off power maybe 3 or 4 seconds. And then on thicker tissues like the ridge, where the consequences of excess power delivery and pop lesions are not severe because they vent into the chamber, we will stay on high power for usually 10 seconds to try and maximize that lesion.
Yeah, one of the things that really struck me when I was operating with you is the use of ice. And really, certainly in Europe, where ice use is not really reimbursed and therefore not used, it was really interesting for me to see the difference in how an ablation is done compared to sort of just using a mapping system and, you know, really just going, I'm going to join dot to dot and then I'll be okay.
Right, right. And so I think it's a great era because many of the leaders, industrial leaders in the field are going to be introducing new systems, new catheters, new monitoring technologies that are going to really allow the operator to know when they're making the lesion, to create effective lesions, and also do it faster. And that's on the end of a long day, you really appreciate the time that you save with these quick ablations that are highly effective.
Yeah, I think certainly in my own practice, we've seen about a 50% increase in the number of cases we're doing per day because you can really get a good workflow going.
Right.
You know that you will isolate the veins. You're not having to go back and say, where do I need to go to?
Absolutely.
And this has made it a lot smoother, and therefore everything follows on from that. Your lab staff know when to call for the next patient because they're like, you will be 15 minutes from this point to the next one being isolated.
Right.
And it's got a lot of knock-on effects.
Right.
Also, I think it really leads to a dramatic reduction in fluoro time.
Absolutely.
So all these things, I think, are making it safer for the patient. But I do share a worry that by having a sort of a magic number, which we've just made up with ablation index or LSI, and we don't know what that means. It just has worked in the past. It's a bit like the Columbia sort of shuttle disaster. Like, it seemed to work. We knew there were problems with foam dropping off, but we should never forget that it is quite dangerous, and you only need one lesion to go wrong.
Right.
And like you said, with the spiking fistula, that's my one worry, that we will just blindly accept these numbers when there isn't really a scientific basis for them.
Absolutely. But it's a good time to be in the field. It's exciting.
Okay. Thank you very much.
Okay, my pleasure, Matt.